I am Dr. Derek Lee. I'm happy to introduce a terrific surgeon who has lots of information, lives in Gainesville, Florida, Dr. Laurel Blakemore. Dr. Blakemore is Schreiner's professor of pediatric orthopedics, also professor and division chief of pediatric orthopedics at the University of Florida, Department of Orthopedic Surgery and Rehabilitation. That was a mouthful.
Yes, thank you, Derek.
All right. Now, I always like to, when I start off with these conversations, talk a little bit about how you became interested in medicine and your career path to the point where you're a spine surgeon now. So I was wondering if you could take us through that a little bit.
Sure. So I came from a family that had some medical practitioners in my family. My dad grew up in rural Pittsburgh, actually. His family were coal miners. And he was the first person in his family he went to go to medical school, and he was a general surgeon. And then my brothers and sisters all kind of went different directions. Some of them, we have a big family, and about half went into medicine and about half went the opposite way into something else. I was really thinking about doing something else. I actually majored in creative writing at University of Michigan, and a little known fact. But I always liked the idea of helping someone. I think my family was really very service-based. So I felt like always in the back of my mind, I wanted to do something where felt like I was of use, I guess. And some of the other career paths I looked at maybe weren't going to let me have that also. So my dad convinced me that I could be a physician or a doctor and still do some of the things I loved, like writing, and I ride horses. But it would be really hard to do those things and still be able to serve people in the way that you can as a physician. So I think he was right, and he convinced me. And so I went to started medical school actually in Ireland, thinking I was going to do something like physical medicine, but was really drawn to the surgical specialties. And so it became apparent that I was going to pick a path along those lines, some kind of surgery, and really liked working with kids of those specialties the most. I just really got a charge out of it. So I ended up graduating from medical school in Alabama and going into orthopedic surgery from there, and kind of never looked back. Spine surgery, it was a little bit of a less likely. Again, I originally thought, having gone into orthopedic surgery, that I knew I might do pediatric orthopedics, but was maybe going to stay away from the bigger cases. But I just kept deviating, sort of going that direction. I found that those were the cases I thought were the most exciting and interesting. And those are some of the challenges, as you know, particularly early onset scoliosis is something that we really haven't solved. And there weren't a lot of good answers then, and there are some better answers now, but it's still a very challenging problem. How do you get a child's spine to continue to grow maximally as best you can with whatever physiologic opportunity there is, without losing control of their alignment and having them get so crooked that then again you're losing those physiologic potential. So I really like that, even though it's hard and can be devastating and frustrating and disappointing for all those reasons that you understand. It's still really what I'm most interested in, trying to help solve those problems.
It's interesting that you're drawn to complexity. And,
yeah, because I'm really quite simple.
True. I have no idea, but I find that a lot of the best experts are the ones that take complex concepts and problems and just kind of boil it down to the real basics.
Yeah.
And that's what they're kind of gifted at.
Yeah. It's never ending. I mean, when I was in residency, one of my mentors, I was very fortunate to have a lot of fantastic mentors. And one of them was Bob Hensinger. Bob Hensinger was what we call he'd done the triple threat. He pulled that off. He was president of the Academy of Orthopedic Surgeons, president of the Pediatric Orthopedic Society of North America, president of the Scoliosis Research Society. He was just a genius and a fabulous thinker. And I would go into his office sometimes when I was a resident. back then you were allowed to smoke, and he was a smoker, and I could tell that he was in the office because I could smell the coffee and the smoke, and I would go in and talk to him, and he was always thinking about problems of growth and how could we influence the growth of the spine. And he was one of the first people that I ever heard talk about using the growth of the spine to correct deformity. And he had a million ideas like that there wasn't enough time in the day for him to get all his good ideas going and turn them into real research projects. But he was a fabulous mentor in the sense of sort of lifelong learning. And I think he's still like that to this day, even though he's stopped practicing now.
Yeah, you're either wired for that or you're not, so to speak, right? Yeah. And I'm going to touch on your mentors a little bit more, but I'd like to go back a little bit to maybe about 17 years when with one of the papers you're writing on women in surgical residency training programs in terms of how at that time it was quite unrepresented in terms of orthopedic surgery for women.
Yeah, it still is, right? So when I was a resident, the percentage of women in orthopedic surgery was really about the same as it is today, I'm afraid to say. We hadn't at that, up till very recently started to really seen any kind of bump in the numbers. And that paper was trying to explore maybe some of the reasons why. We all have stories about what the culture was like back then. I mean, almost every woman my age or older could tell you, horror stories about things that were said, and the way it was to be a token at that point. Now we're kind of a minority, so we can make it better. I feel like still having more women in leadership roles doesn't just fulfill our goal of sort of having the woman there because that's what you should do. It helps all of us learn when all the people that participate in leadership start to understand the benefit. And I don't need to tell you the benefits of having underrepresented groups in leadership in terms of what that does for the organization, what that does for the people that the organization serves. But it's really been important to me to try to make sure that we take it to the next level, that we enable the next generation. And there turns out is a fabulous generation of young women coming up behind my group that are incredibly smart and gifted and, getting more opportunities, and hopefully we're helping them to do that. But I think it's also been important for them to see us in leadership just be present and be able to be successful and know that can happen. And I still see, it's amazing to me that I still talk to students and undergraduate medical students and people that say, well, I never thought about going into orthopedic surgery. My counselor never mentioned that, or they just don't. If we're not visible to the next generation or to trainees, then they're not going to go that, they don't even know it's an option to go that direction. And so some of the things I do in academics have been just being out there and being seen and talking to the medical student groups so that they know it's a really good option. And, it continues to get better in terms of our representation of underrepresented groups. And that's been increasingly important to me actually in my career. I used to, as a token, I just kind of fought it out on my own. I felt like, even though I know that I had mentors that supported me and other women that supported me. Fran Farley was one who's been chief at University of Michigan of pediatric orthopedics for a long time. And there's other women that did that, but the older I've gotten or the farther I've gone in my career, the more I've understood the importance of being there for those people to see in that role and being able to open doors for them and give them opportunities that they deserve.
It's important. In terms of fusion, VBT, because I would like to talk about fusion for sure. When was your first exposure to VBT? Because you did mention before you were kind of aware, you were aware of bone growth modulation and using that as part of a tool, perhaps. When did you start to really investigate tethering?
In 2014, I think. So shortly, I moved from DC, from a Children's National to Gainesville at the start of 2014. And about that time was when I first heard about it at a meeting. I think maybe Peter Newton was the first person that I heard talk about it. And it was, exciting because for a pediatric orthopedist, we really understand or try to think a lot about how growth modulation can help us. And so to use growth modulation in the spine, just like Dr. Hensinger had talked about all those years ago, was exciting to hear that maybe there was a technique that was going to be helpful. And then Stefan Perron, who, as I mentioned, is a friend of mine, had probably one of the other large experiences at that point. And so I asked him if he would come down and mentor me through a first case. And so he came down and helped me with the first case towards the end of 2014 and gave me a lot of valuable pointers. And then I've done it since then pretty steadily up through now.
Okay, pretty interesting. Was it Dr. Perron's work in growth modulation or tethering himself that was, I guess, both, right?
Yeah, both. I think. I mean, as I say, there have been some interesting papers that have been written earlier, like Dan Scotto's group at Texas Scottish Rite had written a paper about trying to modulate curves by putting screws across from posteriorly, kind of across one of the growth plates posteriorly, and that was interesting data. It didn't really turn out to be something that, at least up till now, we've been able to utilize clinically. But also, as you know, there was, even before Peter Newton had sort of talked about his work, he'd been doing work on animal models. John Braun had done some studies on stapling. And so we knew about stapling as a growth modulation technique, but stapling hadn't proven, again, to be as predictable or effective clinically as we had hoped. And tethering, I think, has taken it to the next level in terms of effectiveness. So stapling might have worked on some very small curves, but most of us felt like many of those curves could also have been managed, at least initially, in a brace.
Right.
Whereas tethering seems to work on a wider variety of curves and a little bit more particularly in the thoracic spine, where we really hadn't been able to get on top of things very much with growth modulation up till then. The only growth modulation that had seemed to work was with much smaller curves.
Okay. Now, with I assume you do anterior fusion as well as posterior fusion?
I do. Anterior fusion, as you know, has been as popular in the United States since, about 10 or 15 years ago, when there were some studies suggesting that maybe having that instrumentation anteriorly wasn't necessarily we weren't sure if it was going to be safe in the long term. And it was sort of one of those things that we did for some certain centers did for a while, but then kind of died out in the States, but it's still done in Europe. I know for instance, in Switzerland, there's a very good surgeon who does a beautiful kind of mini open thoracic approach, not thoracoscopic, but a small approach, a relatively short fusion levels, and has very good results. So I've done anterior fusions in the thoracic spine in the last 5 years, but not as often. And again, it's just sort of it's sort of fallen out of favor in the United States for the thoracic spine and for the lumbar spine for a different reason. The lumbar spine, I think most surgeons have felt that as we've gotten more facile with pedicle screw fixation and posterior column osteotomies, we can achieve the same kind of correction posteriorly as we can anteriorly. And then we don't have to look at the morbidity. There is a little bit of increased morbidity associated with an anterior approach for the lumbar spine in terms of a fusion. So, and I think most surgeons who use thoracoscopic approaches and tethering in the thoracic and lumbar spine are surgeons that most of us were already comfortable initially doing either thoracoscopic releases or anterior fusion work.
I guess that's where I was going in terms of if you're already comfortable with the anterior approach. So it led to being a little bit easier or more familiar with the thoracoscopic with the VBT.
Yeah, I did anterior thoracoscopic work I learned it during the end of my fellowship. And so at that time, we were using anterior releases, thoracoscopic releases for large, stiffer curves. Again, that's kind of fallen out of favor in part because we've become more effective in terms of our posterior instrumentation and release techniques. So posterior column osteotomies and segmental fixation has allowed us to get the kind of correction on a 80-degree stiff curve that we used to get by doing an anterior release first and then doing the posterior fusion. So I did a lot of thoracoscopic surgery in my first 3 or 4 years out of into practice, but in the last 5 years, really haven't done just an anterior release for any indication, although there probably are still a couple indications for an anterior release followed by posterior spine fusion.
Okay. Now do you do tethering both in thoracic and lumbar, or primarily thoracic?
Most of my experience is thoracic. I went up and visited Amir Samdani, who I think you've spoken to, maybe about 18 months ago, to watch him specifically do a lumbar tether. And so that's part of the armamentarium, but I have a longer experience with thoracic for sure. What's
the perfect VBT patient for you in terms of parameters, Sanders score, that type of thing?
Well, so that's something we're learning about as we go a little bit. I would say right now, some of the things we've learned are, it doesn't seem like a good idea for anybody who doesn't have enough growth left. So Sanders 3 to 4 is probably ideal. Again, that depends a little bit on the size of the curve. The curve can't be too big. So if it's 70 degrees, you're probably pushing the limit of what you can achieve. Although again, we might consider a tether in a larger curve in a patient with more growth left. But in a Sanders 3 to 4, the ideal curve might be one that's just getting into the range where you feel that surgery is appropriate. So 50 degrees, 55 degrees. In my practice, most of those kids either present with a curve that's too big to brace, or they've failed bracing. I try to utilize bracing initially, because, you know, again, in the right patient, bracing can be effective and they can avoid any surgery. So that's kind of my parameter. So, and the curve has to be flexible, as you know. So that's a, you know, relatively flexible curve that's in the sort of 45 to 60 degree range. And in my practice, typically those patients have either tried bracing and failed bracing, shown progression of their curve, or they come in with a curve that's too big to be braced.
Okay. So kind of within the FDA parameters for tethering now, I guess.
Yeah, I think everybody agrees that, you know, we've all had a couple results where, for instance, we've used tethering on kids that were a little bit more mature and maybe have been a little disappointed with the correction or a little bit too stiff. And that's something that initially, you know, I get bending x-rays to look at the flexibility. There's lots of different ways to look at flexibility. Bending x-rays are subjective. A lot of the things we do are based on evidence that's not as objective or quantifiable as we'd like. And bending x-rays to me are one of those things. So unless the surgeon goes down and positions the patient for every bending x-ray, which is pretty impractical, it's hard to know that was a beautiful bending effort. But if the curve is clearly stiff at the apex, then that's a red flag that that a tether may not be strong enough, or for whatever reason appropriate technology for that child, for a child with a stiff curve like that.
Okay. Well, with tethering, as you know, there's some surgeons who are kind of pushing the boundary in terms of more mature curves or less growth, right? What's your take on that?
So I think in my practice, I don't do that. And I tell patients a lot of times come to us and say they've read about tethering and they've heard about it and would we do it? I feel like in my practice, it's irresponsible to use a technology that's designed for growth modulation in a patient who doesn't have enough growth to modulate. We know from what we understand so far that the tether can fail in a certain percentage of patients. We know that going into the chest more than once we don't really know exactly how much you can do and how often, but going back over and over, for certainly going back open if you have to, which sometimes has to happen with revision tethers, that may have a somewhat detrimental effect on their lung function long term. It may take a little hit long term. So it's not completely benign to say, well, if the tether fails, we'll just go back and put it back in. That would worry me. I consider that suboptimal treatment. If a patient has to have a second surgery, to me, in the most cases, that means that surgery was not as successful as you would have liked. And so to predict that tether is going to fail to hold an adult curve long term is reason enough to really not proceed. I know there's some surgeons that feel that they still see modulation, so to speak, of the shape of the vertebrae over time, so that they feel like a large curve treated with a tether, even in a mature patient, can undergo relative modulation of the shape of the vertebral bodies to the point where some correction will be will exist even if the tether fails. In other words, the correction would hold even if the tether failed. But I don't think we have enough evidence to say that right now. And so until that evidence comes forward, I don't think that it should be part of my practice, at least. And I'm just not sure that we're going to be using it long term for that indication, for those adult patients or for big stiff curves.
Sure. And of course, bone remodeling at the other end of the spectrum, when as the decades go by, goes into degeneration.
Right.
Right.
Right. The things kids can do, if a child fractures their femur bone, their thigh bone, and they're 2, the remodeling is phenomenal. I mean, you just can't even believe that the x-rays could actually be the same kid a year apart. If a 25-year-old breaks his femur, it's just not going to do that.
Right.
That potential is lost. And it's hard to imagine that the spine still has that kind of potential in a skeletally mature person either.
Okay, that's good. Question I have as well is with respect to, since we're already on a little bit of controversial topic, there's also a little bit of controversy regarding disc release, in mature and immature spines, in terms of trying to reduce the anterior column, create more space, because you do discectomies anyway in full fusion, right? Just to derotate and then get into the sagittal plane more. So you'll have along the spectrum surgeons indicating, for instance, like Peter Newton, that in animal models, basically, if you do any kind of incision on a disc, you're reducing the structure of the disc. You're already compromising it. And you have the other spectrum where it's almost like full discectomy to try and reduce the column. Where are you in that spectrum? I kind of already know, but I just need to ask.
Well, so here's how I think about it. And one of the beauties of my profession is you're always learning. So in 10 years, we may know a lot more. We may be able to say, oh, we were wrong. Today, what I understand about disc function and health is that one of the goals of this surgery, as you know, is to keep the spine flexible. We don't exactly know what that benefit's going to be. So the things we don't know yet about tethering, but we're looking at are, is it really going to be helpful to have a flexible spine? Well, that patient, we want to know if our patients that have a tether 30 years from now are going to be doing way better than patients with fusion, or the same, or not so good. Better would be that would vindicate our hypothesis that having flexible discs and not having a stiff fused segment of thoracic spine is going to improve the long-term outcomes, because all of the discs will stay healthier, as opposed to fusion, where in theory fusing a section of the spine will have some detrimental effect on the patient overall in terms of their long-term health. We could be wrong. What if it's possible that tethering will cause some injury or long-term detriment to the disc that will result in pain or something that means that the patient ends up with a fusion? You could say that that's a really good outcome because they avoided a fusion for 30 years, or you could say that it's a suboptimal outcome because they ended up having to have 2 surgeries. So if our goal of tethering, one of the goals, is to keep the disc healthy and flexible, it's hard for me to imagine that doing an annulotomy or taking out a portion of the nucleus of the disc, which is the functional part of the disc, isn't going to have some detrimental effect long-term on function or outcomes in terms of patient satisfaction. They're going to have pain or something. I could be wrong. Maybe those levels will fuse. Maybe if you do an apical annulotomy or release, those levels will autofuse. But then fuse them. Then call it a fusion and fuse them. To loosen them up by injuring the structure of the disc, which is a pretty complicated functional unit, I think is not the right answer. I worry about the long-term outcomes of doing that. I would love to be proven wrong on that, but that's my concern.
No, thanks for sharing that, because we need to know the pros and cons and different perspectives for sure. Okay. Now, in your practice, do you guys keep, I assume you keep records on tether breaks, revisions, overcorrections, that type of thing. Do you have an idea of, can you share those with us?
So our rate of tether failure that we've identified. So, and I haven't gone back in on a lot of tethers. I have, over the 6 years of the patients we've had about a 10% rate of eventual failure of the tether at some level. None of those to date have been revised, but I have recommended a posterior spinal fusion in one patient. So that's less than 10% for sure of the group. But again, to me, that patient's curve progressed. She was a little bit older when she had a tether. Maybe didn't have enough growth modulation potential left. So she got some initial correction, and then the curve started to creep up over time. And now at about 5 years, I think, I've recommended a fusion because I'm concerned that that curve's just going to slowly keep increasing. We've had one patient that came to me from an outside hospital that was clearly overcorrected, and it's an impressive proof of concept. If you wonder whether growth modulation really occurs, I can show you at least one case, and there are other surgeons that have these cases where the curve went from a 40-degree right thoracic curve, was tethered with what looks like pretty aggressive tensioning of the tether, and now is 40 degrees the other way. And that child I performed a release on, and she did that fast. She did that in about 18 months. She was lost to follow up for a period of time because of insurance reasons, and so they can it for sure can make the spine straight, because it for sure made this spine go from straight to the other direction in a relatively short amount of time. Those are the things we really need to fine tune. When do you know, what patient is at risk for overcorrection? What patient is at risk for undercorrection? You know, what's the optimal curve range and age are matched and will change as one variable goes up, the other might go down, and so on. So that's what we're really trying to fine tune now. And so everybody that I know who's doing this, fortunately, is looking really closely at their results. We're trying to very carefully track patients pre-op and post-op. I look at motion analysis. I've started doing PFTs, and we're trying really hard to be as scientific about it, so to speak, as possible, so that we can identify for patients what's the best option for them.
Right. And I know that, talking to Peter Newton as well, he was in the middle of a study with respect to using the EOS system just to track three-dimensional bone growth modulation month by month, just to try to get a little bit more accurate estimate of how much growth to expect. A question I have for you is, have you noticed that curves generally progress due to, of course, the cause of idiopathic, for instance, unknown by definition, but anterior vertebral overgrowth or RASO, for instance, leads to hypokyphosis, which lengthens the spine, and the spine reacts by rotating, and then you have the coronal scoliotic curve. Have you noticed any correlation between a greater severity of hypokyphosis, maybe even lower doses in the thoracic spine, and more tendency for tether breaks or less correction?
I have not, and I don't know that anyone has identified that, although that's a really interesting question. We were worried initially that tethering might cause kyphosis, and that was my worry about the lumbar spine. That's why I really didn't proceed with lumbar tethering for the first few years, because I thought, well, that's anterior instrumentation can be kyphosing, and so in the lumbar spine. So what makes us think a tether wouldn't? I will say that it's surprisingly, we haven't seen as much modulation of that sagittal plane, kyphosis and lordosis, as we expected, neither in the thoracic spine nor in the lumbar spine. Those kids, for the most part, do not seem to be becoming kyphotic or losing their lordosis. So that's really interesting, and I don't know that we have an explanation for it. But as we get bigger numbers, like Feroz Morangi that you mentioned has quite a big serious Stefan Perrant. So as we're in groups now where we're all putting our numbers together, and as we look at that, we may be able to identify that clearly if you have apical lordosis, that's going to change the outcomes or increase the breakage rate, like you said. We do EOS here too, and so that's also going to be another important component, is looking at the 3D correction. Although it's not like you can't just get that on every case. It's quite labor intensive to do that work.
Okay.
Peter's really well set up to do that. Stefan Perron's done a really good job looking at the 3D changes. The other thing, just in terms of predicting outcomes, that I want to mention, because this technology gets a lot of hot press about being motion sparing, and we think it is, and there are some little bit of early evidence that it is, but the questions about that are how motion sparing, which we're trying to understand. So like here we're looking at all our Tether patients pre-op, 1 and 2 year post-op, and our selective fusion patients, our thoracic fusion patients pre-op and post-op, calling that kind of our gold standard of treatment as we stand now.
Sure.
And saying, how much more motion does tethering spare compared to a fusion? Because that's really the other option you're going to give most of these patients. And then the harder questions are, what does that motion mean? If you can document an increased motion, great, but does that translate to a better outcome for those patients? Better functionality, better flexibility, less pain, whatever, in the short term, meaning, while they're still children or adolescents. And really the hardest question, and this is always true of studying pediatric orthopedics, is in the long term. By the time that child that I do a tether on is 50, I'll be gone. But it would be, but what we really want to find are some ways to predict those outcomes longer term, and how can do we have to wait that long to do that? And that's the challenge. If we look at algorithms, and you can look at Bayesian algorithms and all kinds of things to try to predict that. But that's really what we want to do, is say she's going to still be doing great when I'm long gone.
Yes, because that was part of my decision as well when we went with VBT, because you have to project 40, 50 years into the future, and go with your best guesstimate and hope that works. And of course, and one of my thoughts on that was just, he was in the VBT in terms of Sandra score 3B, and at a later date you can always kind of default to fusion if that fails, or if the curve is just uncontrolled in terms of options. So it does give you a little bit more options as well, right? Okay.
It does, and it's great that I'm sure that your surgeon went through a long explanation of the pros and cons, and it's hard to explain that in a 5-minute or 10-minute setting. You really there's a lot to think about when you're thinking about this, and a lot to go over. And I almost feel like if you're considering tethering for your child, it's good to talk with the doctor, go think about it a little bit, talk with them again. And so that you understand that, it's hard to admit that we don't really have those answers, and we are making an educated guess. Nobody likes to think about using an educated guess on their child's well-being, but we find the very best evidence we can. We try to stick to it and present those options to you. And then ultimately, this is a decision that you make with your surgeon. It's obviously never should be something that the surgeon tells you, this is what you have to do, or this is what you should do. I can tell you why this thing might come out better than this thing, or why I would recommend this, but every surgeon needs to have that conversation with the family about the pros and cons, and why we're doing this, and what we think the long-term outcome is going to be. Because I don't know, I really don't know any surgeons who do this just out of any motivation, really, other than wanting to find the very best way to treat something and do something. But that's an important conversation for sure.
Well, my son did have tethering 7 months ago with Dr. Samdani, and it was so funny because I've done tons of research. Now, even about a year after I've been doing research, I'm learning so much more talking to doctors like yourself. But at that time, I felt, Dr. Samdani, are you trying to talk me out of VBT? In terms of giving me the pros and cons. So but you have to hear, the transparency is huge, which is another reason I want to do these videos, to get the information right from the surgeon's perspective.
I would say if your surgeon isn't giving you the feeling that they're almost not trying to talk you out of it, but that they're really putting everything on the table for you and leaving the decision in part to you, if your child's a candidate, if that's not happening, then with any new technology, then you really, that to me would be a little bit worrisome. I mean, I think a new technology, the less we know about the long-term outcomes, the more important it is to give the family all of the information we have. And it's hard because it's a lot of technical jargon and a lot of what ifs, but all that stuff is important to consider for every family, I think.
For sure. So if a case is not within the tethering parameters, you have to be, of course, transparent with the child and the parents in terms of, this is probably not the best, or they've missed the timeline and all that, which is such a pity with VBT, because you probably shake your head sometimes and you're going, oh, I wish I'd seen this person about a year ago, that type of thing, right?
Yeah.
So how do you handle that in terms of talking to the patients about that if they've already kind of wanting the VBT to begin with?
That's interesting. I've certainly had that conversation, and I'm pretty I stand pretty firm on not making that recommendation or even offering that as an option for patients that I think have, most importantly, not enough growth left, or too small or big a curve. If I think the curve's too small, I really don't offer surgical intervention, although I know sometimes people are unhappy with those curves that are maybe 30 or 40 degrees, but they hate the way they feel or look with them. At this point, I don't think most surgeons can justify surgical intervention if a curve is likely to be stable in that range. I'm sure some of the patients that I have met with have gone to other places and had tethering if that's what they're determined to do. But I just have to give them I kind of follow my conscience in terms of what I think is the best thing. I also think that social media has really changed our world and medically, from our standpoint. So there's things that some surgeons 30 years ago probably never thought would happen in terms of patients networking, and I think that's all, for the most part, really positive. So I think my patients have told me that the words have gotten out that I'm just not going to probably offer a tether procedure to a patient who's 17 years old and finished growing. And so I don't see as many of those patients as I did 2 or 3 years ago, which is interesting.
Oh, okay.
So I probably had less of those conversations in the last 2 years than I did in the 2 years prior, just because, for better or worse, my recommendations have gotten out there kind of in that community of patients a little bit that network on social media. Right.
I totally understand, but you have to go with what and what your experience is, for sure, and what the what the research says. I have a couple of questions about fusion before I let you go, if that's okay.
Yeah.
When is the best time to consider fusion? Is it when the child has very little growth left, or is it when they're fully mature? There seems, because I'm not sure what the decision making for that is.
Yeah. I don't think we certainly don't recommend that you have to wait until the growth is finished before proceeding. There's there's some different things that factor into our decision to recommend a fusion. So you can consider fusion in a child as young as, for most of us that treat patients with early onset scoliosis, 9 years old, which there's cons to that, there's downsides to that because of the growth remaining. So it's better that you can wait till 13 or 14, but sometimes you don't have that luxury. The curve's already gotten too big, and you have to consider some surgical intervention. And if they're not a candidate for whatever reason for tethering, then infusion is the option. Then to me, that's fairly straightforward in terms of decision making. Okay. It's not better. There are some curves. If a child's got a 50-degree curve and they're 9 years old, sometimes we'll try to buy some time with a brace, for example, knowing that the curve might get a little better, but that's probably not going to change our recommendation, just to get a little more growth. And the same with a curve that's maybe 45 degrees, 50 degrees in someone who's approaching skeletal maturity. I don't think you have to necessarily jump in. You could still get the same correction typically if the curve changed a little,
Mhm.
What you hate to see is a patient who has an option for a relatively smaller fusion or a selective fusion, and then is lost to follow up and comes in 2 years, and then it's
Mhm.
a bigger operation with more work to get this, try to achieve the same degree of correction, or you have to extend down into their lower spine or their lumbar spine because now that curve's gotten bigger and stiffer. And that always breaks my heart because I'd much rather have had the opportunity to treat it with as little fusion as possible. We try to minimize the amount of spine we fuse
Mhm.
ever, in all situations. And sometimes you have that opportunity, and then if you see that opportunity get lost, that's when you really, that's really makes you sad. But there are some curves we can, like I said, we can try to nurse them out a little farther until the children are a little bit older,
Mhm.
or until it's a better time for them to get it done, and still have a really good outcome. So it's not like you have to jump the gun right at 50 degrees
Mhm.
for any curve, but 50 degrees is roughly our cutoff for saying, yeah, it's at higher risk now to slowly get bigger over time, and you should consider intervening.
I have a question about the a balance curve.
Mhm.
So if you have, a 30 plus thoracic, 30 plus lumbar, or even greater, um, how do you approach that in terms? If it's perfectly balanced, you just leave it be, or it just depends on how severe the curve is.
It depends on how severe the curve is. The balance, I think the balance is two things. One is patients can tolerate, I feel like, a balanced curve better. And in particular, a lumbar curve sometimes will really throw the patient's waist off to the side, so their shoulders are not centered over their pelvis anymore. And I think most surgeons find that those curves aren't as well tolerated, even in the 40, 45 degree range, because they hate the way they look and they feel off balance.
Mm-hmm.
And some of them really have back pain that we think is probably in part due to that unbalanced lumbar curve. Whereas a thoracic curve in that range, even if they don't have much of a lumbar curve, they're usually not super unbalanced. And a double major curve that you described, like a thoracic and a lumbar curve in that range, may look very good and feel very good.
Mm-hmm.
So, for example, if you have a patient who's got a balanced thoracic and lumbar curve and they're super athletic and they really want to finish out their high school athletics before they consider treating, again, if the curve hasn't gotten too big, that's not an unreasonable decision because they'll preserve their mobility at least during that time, and you can maybe delay the surgery a little bit.
Right.
If their curve's getting bigger and bigger and bigger, you got to consider treating it in a child that's still growing. If they're up into that surgical range and they've still got significant growth remaining, there's really no advantage to waiting for that child. So we should for sure consider the balance and look at the balance, and that's what the patient sees. We're getting a little better at understanding how important it is to consider what the patient sees and feels about their curve, treated or not, and try to help use that to influence our recommendations.
Okay. My final question for you is looking into your crystal ball into the future. Because fusion is, the gold standard right now, and VBT is quite a narrow parameter.
Yeah.
Is there anything that's going to kind of fill the gap, or do you see anything in the future that might indicate different types of approaches?
I think my hope is to be put out of business, really. In a perfect world, we would be this close to some sort of a biologic or a non-invasive treatment that we could identify patients by genetic testing who are at risk to get a larger curve. And as soon as we see evidence of curve progression, we can use something that doesn't require them to have their back opened up and fused. It's hard to believe. Sometimes I think, gosh, that's really still the best we can do is to make a big incision and pull the muscle off the spine and fuse all the joints together and put rods in. It is, and people do remarkably well even with that big a surgery. But I know we can do better long term, and I believe we will. And I think it may be a stepwise progression through some relatively more minimally invasive surgeries like tethering, to the point where maybe surgery isn't necessary for all those curves. That would be a great day. I really believe we will get there, but it's not going to be tomorrow. In the meantime, we have to think of more structural orthopedic, I guess, ways to
Solution.
treat these patients and give them the best long-term outcome we can today in 2020.
Okay. Thank you so much, Dr. Blakemore, for your time.
Thank you. It was fun.
Okay. Have a great day.
I'll talk to you later.